Hello, this is Manny Ramos, your host of Rise Up, Real Issues and Stories of Every One of Us podcast. First, let me talk about who we are. I'm Manny Ramos, a board member of PNAA, a past president of the Philippine Nurses Association of Central Florida. I'm a professor of nursing at Valencia College in Orlando and an adjunct faculty at William Patterson University. With me today is my co-host, Mindy Ofiana. Mindy?
Thank you, Manny. Welcome, everyone. As many have said, I'm Mindy Ofiana, Legislative Committee Chair for PNAA, Corresponding Secretary for PNAA Foundation, and past President for PNA Southern California, and currently an adjunct professor at Charles R. Drew University, Department of Medicine and Sciences. Manny?
Thank you, Mindy. Our guest today is Dr. Darlene Acorda. She's a clinical specialist in the Pediatric Intensive Care Unit at Texas Children's Hospital and a pediatric nurse practitioner in the community. She's also an adjunct faculty in the undergraduate program at the University of Texas Clark School of Nursing and currently serves as the chair of the Clinical Practice and Research Committee of the Society of Pediatric Nurses. Her research focuses on the experience of children with medical complexity and their caregivers, especially those who are tracheostomy and ventilator dependent. She has received funding support from the Society for Simulation in Healthcare to explore how family caregivers perceive the use of high fidelity simulation in learning tracheostomy emergency management. She also received funding from Sigma Theta Tau Zeta Pi chapter to examine the challenges of caring for a child with medical complexity during a global pandemic. Her other research interest is in minimizing pediatric health disparities, improving the rapid response of critically ill children, increasing cultural competence in care, and merging research and quality improvement methods to implement interventions with a positive, sustained impact on the care of hospitalized children. Dr. Darlene Acorda, welcome.
Thank you. It's a pleasure to be here.
Okay. Good to have you at Rise Up, Dr. Acorda. So, how do you want us to call you, Dr. Acorda or Darlene?
Darlene is fine.
Okay, so Darlene, where did you grow up and how was your upbringing and was that a factor in where you have become right now?
Sure. So I'm a first generation immigrant. I was not born in the United States. I came here as a result of the nursing wave in the late 80s, where Filipino nurses were being hired by hospitals to help with the nursing shortage, and then also at that time dealing with a different pandemic, which is the AIDS pandemic. So my mom, she first worked. She was hired in a hospital in New York, where I don't think that hospital is there anymore. It's Roosevelt Hospital, middle of the island in between the boroughs. And she came in the late 80s, and then a couple of years after that, in the early 90s, was able to bring her family, my dad, my brother, and myself. And I grew up sort of all over the world, I guess. I grew up partially in Mindanao. My Davao is my home. That's like where my family is from. And then I, went and grew up a little bit in New York. And then all of a sudden in the late 90s, my mom decided that she wanted to go and migrate again to the South. My dad didn't like the snow. He missed the Philippine weather. And we came to visit in Houston. And that was it. That was the place for them. So she became a nurse at MD Anderson and stayed there until her retirement. So she's a hematology oncology nurse, research nurse later on in her career. And I grew up partially, I can call myself a Houstonian now. I've been here for more than 20 years. But I think my background has sort of, in a way, as crazy as it was, growing partially in the Philippines, growing up in New York, growing up in Houston, I think has really contributed to who I am today as a nurse and also as a researcher. My mom has been the biggest influence. She is always striving to get more educated and doing different things. So she was the one who sort of, after my bachelor's, said, do you want to be a nurse practitioner? Maybe something to think about. And then after I became a nurse practitioner, she said, I see a lot of PhD nurses in my work at MD Anderson. What do you think about that? And so then,
That's nice.
she has been
That is
the
neat.
propeller throughout the whole course of my career,
Yeah.
and probably my biggest supporter. So I have her to thank for all of that.
I see.
That is wonderful. Now it's good to learn that you were born in Mindanao in Davao, right?
Yes.
And how old were you when you moved to the U.S.?
I was 8 when I moved to the
I
US. Yes. And so,
Well, you do have some
I,
memories then, a little bit, maybe.
oh, I still speak Bisaya. I
Wow.
speak Tagalog, and I can understand Ilonggo because my mom's from Iloilo.
Wow.
So that never left me. My parents were very clear that you learn how to maintain your language at home. So
I see.
yeah.
What's your fondest memory of Davao?
Climbing mango trees as a child. And just picking fruit,
Right,
that
right
like
off the
nobody
tree.
cares.
Yeah.
Yes, the freedom,
Yeah.
the freedom as a child
Yeah.
in Mindanao
That's right.
was probably what I miss the most.
I see. So,
Yeah.
other than being a researcher, your first degree immigrant, as you have mentioned, climbing mangoes, what do you think? Can you tell us something that's interesting about yourself that no one knows?
My husband would probably be like, "There's a list." I think so. I'm also a potter.
Oh,
I do
wow.
ceramics, and
Wow.
my initial degree when I went to college, when I applied, was actually I had intended to become an art historian. I was going to go back to New York, and I was going to go work in a museum.
Wow.
And I still loved science, and but I was always in the back of my mind. But I thought, okay, I really like to do this, and so I pursued that, and then quickly realized that the science was too compelling. It was too compelling. It was drawing me too much. So I actually switched my degree and into nursing at the
Wow.
University of Texas. But yeah, so I think the one thing that it's not a secret, but a lot of my friends, my close friends, know is that I use art as a way to cope with all the stress of, nursing and medicine and what's happening with the world now. So I paint and I do ceramics, and I try to stay creative because I find that helps you in your research
right.
and being an out of the box thinker as a nurse. So
Right.
yeah, those are sort of the things that I do on the side.
Wow. First time to hear a guest who's a potter.
Yeah, that's exciting.
I
That is
know.
exciting.
I was later in my life that the pandemic made me a potter. I would say that's how I ended up. My husband bought me a pottery wheel, and
Yeah.
I decided to try it, and I love it.
Oh, wow.
So what have you
Yeah.
produced so far?
Oh, little things.
Is it
Mostly-
vases or what are they?
Mostly wine glasses for my friends.
Oh, okay.
wow.
Something
Yeah.
useful, just
Yeah.
a wine glass that you can use.
Yeah.
Because, the pandemic has been
Yeah.
quite stressful to a lot of my nurses, or my friends were nurses. So I've been making them something that they can use.
Amazing.
Interesting. So so you started to talk a little bit about shifting your career, your education, going into the sciences. But why nursing?
That's a good question. So I was pre-med. I actually went into when I first went into college, my first year, I was pre-med and I was art history. And then I my mom, again, who is very practical, said, well, you should, just in case, why not consider nursing and then maybe go back later on and pursue pre-med, and that way you get more experience. But I also did a lot of volunteer work at MD Anderson as a student in high school.
I
So
see.
I was always exposed to nursing. My mom is, when she was in the Philippines when I was growing up, she was a more like an occupational nursing for one of the bigger the banana plantations in Mindanao. So
Oh.
I don't have a memory without being in a clinic or without, seeing patients in a local
Ah,
community hospital. All of my childhood memories has some form of nursing somewhere in
I
there.
see. I
Um,
see.
but I think that the reason why I became a nurse specifically when I did, during college, was really because I really felt like that was the closest thing I could get to spending more time with my patients. Um,
Okay.
and then I went back actually after I graduated. I tried to do pre-med again to see if I still wanted to move forward with that path. And I took organic chemistry, finished all of that, and decided that just was not the path for me anymore. And I wanted
Uh-huh.
to take nursing and kind of see how far I could go with nursing instead.
I
So,
see.
yeah, so that was
All
the reason.
right.
Mhm.
That's nice. Nice path. Anyway, it was mentioned by Manny a while ago during your introduction that your research focused on the experience of children with medical complexities. Who are the children with medical complexities?
So they are a population of children that I don't think people quite know or understand completely. In the sort of the general pediatric population in the United States, you have children with special healthcare needs. So you have children who have maybe diabetes, or they have long-term chronic asthma, or maybe they have cancer, or they have sort of these long illnesses. But there is a subset within this category of children with special healthcare needs called children with medical complexity. And they're really defined by four very distinct things now. Before 2010, we didn't really quite understand how to define these kids, but since then, there's been a movement in pediatrics to really be clear of who these kids are, and they are, to put it simply, the sickest of the sick of your children with special healthcare needs, in your general population of kids. So typically, they are children who have life-threatening or life-limiting or severe illness. They have another one is a part of their definition is that they have to have a very severe limited functioning. So oftentimes these children really cannot be carers for themselves. They really are dependent on others, specifically their families, to take care of them. They are also they are very high users of healthcare services. So these children, even though in the overall population of pediatrics, all children in the United States, this population only makes up about 1% of that total population, but they make up a third of healthcare spending in pediatrics in the United States. So they are high consumers of healthcare services. And then the
Yeah.
fourth is that they are dependent on some kind of technology, whether that be tracheostomy, maybe a combination of tracheostomy and a ventilator. And so these kids over the past 10 years have even become more, I consider them chronically critically ill, because they are going home with conditions that we had never even thought was possible to send kids home. And then they are being managed in the home, not by medical providers like ourselves in the hospital, but their families. And so the gravity and the intensity of care that they receive from their families, not from healthcare providers, is very very stressful, very extensive. So that's sort of a growing population of kids. As we've gotten better with keeping kids alive after they've been born and have increased the survivability of NICU babies, well, they have to go somewhere. They can't stay in the hospital forever. So that population has really has kind of boomed over the past couple of years. And I can foresee that it's going to increase even more over the next decade or so.
So, Darlene, now can you tell us what are the biggest opportunities or unique challenges faced by the children with medical complexity or CMC and their caregivers pre-pandemic?
So I think that's a good question because this is normal without any stressors that a global pandemic brings. This population of kids, especially their caregivers, so their parents and family members, are compared to other families of children with special healthcare needs, and certainly compared to families of healthy children, have much higher rates of depression, much higher rates of stress and anxiety. They have been found to have PTSD from very traumatic events that have happened to their children. And they also have much poorer quality of life compared to parents of other types of kids who are not this complex. So before the pandemic, this population is already at high risk for generally just lower, mental health status and poorer well-being. And so then you add this layer of a global pandemic, you can only imagine how much more of a stress that is. To put into kind of perspective, these families tend to be single income household because one member has to stay at home to take care of a tracheostomy ventilator dependent child 24/7. They don't receive the type of nursing support that you would think they should receive, mainly because Medicaid and the type of support that we allocate to these families are not the best. And then typically they are at a lower income level because of the choice to have only one parent work. So then, that's just one child. But if they had other children, there's also the stress of having to manage a whole family with a medically complex child. They have up to, I think, there was a case that I saw where a child had about 58 different subspecialties and therapies that they would have to see in a span of like 6 months. So these children are just very, they have high rates of morbidity, so they die quite often, not quite often, but they have higher risk for dying at home. And then when they do have an event that happens at home, their risk for mortality and morbidity goes up even worse. So that's sort of the status as of pre-pandemic. And so when the pandemic came, I was really concerned for this population because during the lockdown, during all of these things that were, sort of implemented as good public health measures, they had no access to healthcare services that they needed to get to. They didn't receive the same therapies that normally they should have been receiving at home. All of that sort of stopped. A lot of the surgeries that we would schedule for these kids to kind of help them. So a lot of those surgeries in the pediatric hospitals across the country had to stop. So a lot of these, procedures and tests that we needed to run to kind of make sure that they were in a good trajectory kind of basically paused for a good, year into the pandemic. And so then on top of that, the loss of jobs. I had a mother who I interviewed, and she told me that she would rather not pay her mortgage instead of not paying her insurance because she was worried that she could not get coverage for her medically complex child. And so she and her husband had lost his job at that time. So there was a lot of, job loss and unemployment as well. So all of that, and then the fear that kind of was circulating. That's another, another side there. But so a lot of the families really and continue to struggle to this day, just from the impact of having to experience this huge public health crisis.
So, how has COVID posed different challenges for this population versus the healthy children?
So I think that so for me, when COVID was starting, I work in the pediatric ICU. I'm a clinical specialist, so we were so busy trying to figure out how bad is this going to be in kids in general. So we were preparing, sort of preparing, anticipating that this was going to be as bad as what we were seeing in the adult population. And thankfully, that wasn't the case in the pediatric world. Most of the children that got COVID, they, generally were doing fine. There is a subset of children that were hospitalized, and that those were typically the teenagers who were either obese or had diabetes or had other comorbidities. But the population that we did see in the hospitals, at least at our institution, were those kids that already had comorbid conditions, congenital heart disease. So those kids who are medically complex already. So that when they did get COVID, they're already immunosuppressed, they don't have as much reserve, and they were already at risk for, anything to really send them to the hospital. And so those were the kids that we started to see more rather than just healthy children. And I don't think that unfortunately, there wasn't as much focus on that, I think, in the media, so most of the media kind of focus on healthy children. Well, COVID wasn't
Right.
hitting healthy children as much. So this is good and this is that. But I do wish that they should have focused more on the kids that were getting affected, that we were still seeing, even though they were smaller in numbers, that when they did get affected, they had some pretty severe outcomes from that, because I think that was part of the frustration from the families, is that people weren't being careful, and that a lot of the families I spoke to for my research really chose to self-isolate because
Right.
of the risk was just too high for them, and they felt very frustrated that people weren't taking this pandemic seriously in the beginning. So I think that's really the impact, is that, unlike normal children, these are the kids that you should be very, very focused on in a pandemic. And even though it was good that normal children were not getting affected, that there is this subset that when they do, it is quite severe in that population. And so if you can imagine, if they're already high users of healthcare services and high cost, having a hospitalization of a child with medical complexity during a pandemic increases that cost even more. So I think that's where that wasn't as discussed as much in the media during the pandemic, and still isn't. I don't think I've seen that since then either.
So, Darlene, what are the needs of CMC and their caregivers that are still left unaddressed 2 years since the start of this pandemic?
Yes, a lot. I think in 2018, Congress had passed an act called the RAISE Act, which really focused on caregivers in general, and really trying to recognize that more research needs to be done in caregivers, and kind of acknowledging that caregiving work is different from being a parent, that those things should be recognized separately. And, caregiving work for someone who have an elderly parent is different from being their child. But I think the pandemic sort of made it kind of amplified the gaps, the big gaps in the US on how to best support these families. And one of the biggest things that has been sort of circulating around is that we should consider caregivers of children with medical complexity to be like frontline workers, because they are essentially us in the home setting. And so when we roll out these initiatives like the vaccines was available first and foremost for healthcare providers, and it took some time for the general public to be able to even access those vaccines. There is a move now to really change that and to include those who are caregivers of immunocompromised individuals, as well as those caring for children with medical complexity, in that first line approach, so that they be included along with healthcare providers in order to receive these vaccines first. So there's that focus. And then I think the other thing that we haven't really even quite begun to address is, how do we start to support them better in the home? Meaning, how do we provide them respite so that they get a little bit of time for themselves, and that we can provide them nursing support. I think that's going to be a long game. That would take changing our entire perspective on how we allocate care in the home environment. But so lots and lots of things that still haven't really quite gotten addressed. Some of the things that parents have spoken to me about is that at the beginning there was really no source of truth when it came to what was happening with the pandemic, and so they were getting mixed messages. And I think that was just sort of part of that. You can't help. You're sort of in the middle of a pandemic. You don't know, the research is coming out so fast that you're trying to catch up. But just simple things like, is there a place for families to really go to so that it addresses their main concerns, whether that be from larger organizations like CDC that's really related to the condition of their children or their situation. There was a lot of questions from families about the vaccine, for example. So one of the most frequent ones that I received from families at the beginning of when we started vaccinating children was that, well, they're in a million medications. They're on this medication, that medication, this medication. How is this going to interact with the vaccine? And is the vaccine going to make their condition worse if they already have a neurological condition? Some of the side effects of vaccine in general is you can have something like Guillain-Barré, which is that sort of temporary paralysis. And so a lot of our families were like, well, he already has part of that. So how do we know it's safe for my child who can qualify for vaccine? So there's a lot of questions that were never and have not been addressed for this population. And so I think the assumption is that, you have a child with medical complexity, of course you're going to want to vaccinate, but that's not always the case. Families have a lot of questions, and a lot of those questions are left unanswered.
I don't know if there's a different program. I have another question, but I just want to share a comment because respite nursing on Medicaid here in California is approved. So I don't know why in Texas it isn't. So that's my opinion only. But I have a different question.
That's correct.
How can healthcare providers, just a comment, how can healthcare providers such as nursing can support CMC and their caregivers during a global health crisis?
I think the first thing is to recognize that caregiving is work. I think that a lot of people assume that because it's their child, that it's like you as a parent, of course you would give everything, and so a lot of families feel that that's sort of it's a crippling expectation that they are not allowed respite because that's my child, and the assumption is, of course, you would do everything for your child 24/7, 7 days a week. But I think for healthcare providers, when you do have a patient who is a medically complex child and they have families around, something's as simple as just turning the focus on the caregiver and just asking, how are you doing? And not caring so much about, do you have the resources that you need to have the medications that you have at home? And do you have questions about how to take care of this condition? Or do you have questions about how I can teach you about your child? But really just sort of just focusing on them and asking, how are you? Is everything okay? How are you coping? Do you have sources of support outside of the medical world that you can turn to when things get really rough? Every time I ask families that question, it's like I can see this just wave of relief of just being recognized. And I think that is the biggest thing that any nurse can do for a parent of a child with medical complexity is recognizing that they are not just mom or dad, but there is also this other role that is very unique and very demanding, and just being able to, even for that moment during that shift or that day, to let them just let you know how they are and asking them about their own mental health, their own mental well-being, and seeing what they need for support. I think that's where it starts, because then once we start to recognize that these two things are separate and they're very stressful, then I think it changes how we approach things. When we're educating families and
Nice.
when we're sort of scheduling tests and doing all of these procedures, that always being in mindful about the fact that there is a parent there, yes, but there is also a caregiver there.
So, Darlene, as we end our conversation, please share to our viewers and listeners your last thoughts about the children with medical complexities and their caregivers. Anything that we haven't discussed or asked you.
Lots, I could go on for like hours. But I think in light of all the things that are going on right now in the world, I think that the at least the most current and pressing things that we are looking at in healthcare certainly applies to the population of children with medical complexity and their caregivers.
Mhm.
We talk a lot about in this podcast about just what's it's been like during the pandemic, but I want to kind of impress that this is in addition to what has already been happening. This is not
Mhm.
this all of this is not
Right.
it began with the pandemic. No, these are gaps in our system that have not been addressed, and also that even though I'm talking at a higher level of general caregivers, that there are experiences here that are unique to caregivers of children who of minority background, of those who are
Wow.
disadvantaged. There is a lot of disparities within this population as well.
Mhm.
And then also the experience of those families who don't speak English to have to navigate this
Mhm.
world of healthcare with a child that's very medically complex. We are just starting the beginning of that work, and that is still left unanswered. What that's like for a family who maybe speaks Spanish or who may speak Arabic or Vietnamese, and having to figure out now how to learn all this care, manage and navigate a healthcare system as complex as ours, and not speak English. So I think that
Mm.
even in this population, those disparities are very real, and I just want sort of people who take care of these kids or are around these types of families to be very cognizant of that, and really be empathetic to what they're going through, because I say it every single day. I would not even imagine me, and I'm a pediatric
Mhm.
ICU nurse. I know how to manage these trachs and vents. I could not even imagine having one like that at home with me. So just kind of always keeping that in mind.
Right. The care of children with medical complexities. That is all that we have for this episode. I want to thank our guest, Dr. Darlene Acorda, and my co host, Mindy Ofiana, our director and producer, Rodney Cahudo, Carol Robles, PNAA Chair for Communications and Marketing, our advisor, PNAA Foundation President Nancy Hoff, and our executive producers, PNAA President Dr. Marijoy Garcia Dia and PNAA Executive Director Carmina Bautista. Join us here next week. Until then, keep on rising. See you then. This publication was made possible by Cooperative Agreement CDC RFA IP 21-2106 from the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of CDC HHS.